Hello and welcome to our expert panel discussion from the DeBakey Heart and Vascular Center. I'm Dr. William Zoghbi, Chief of Cardiology here at Houston Methodist, and it's a pleasure to welcome you to this episode that will discuss a topic that we usually do not discuss often, which is the effect of the environment on health and particularly cardiovascular health. And with me today is a panel of experts from Houston Methodist who've really dedicated their academic career to studying this field. On my right side is Dr. Khurram Nasir. He's the head of our Division of Cardiovascular Wellness and Prevention. And he has studied the effect of social determinant of health in a major way. On my left side here is Dr. Eleonora Avenatti, who specializes in the area of cardiometabolic health and prevention of obesity, and Dr. Sadeer Al-Kindi, who's truly one of the national and international experts on the effect of the environment on cardiovascular health and health in general. So we want to have a lively discussion among all of us. Dr. Al-Kindi, I love a term that you and your specialty has brought about, which is called the exposome. This was news to me. I can decipher what it is, but tell us a little more about it so our physicians, healthcare professionals know, and I think have it in their nomenclature.
Right. So the exposome comes from exposure in omics, in a sense. The term started when people started to study the exposure, similar to what we study genomics and metabolomics and transcriptomics and so on and so forth. And we're realizing that the exposures that we're exposed to, from the birth to the moment we die, is just not simple, enough. It's not just exposure from air pollution, but there's so much exposure that we are exposed to, all the way from air toxics and water toxicity and air pollution, and also noise pollution, light pollution, and so on and so forth. The list really keeps growing as we continue to understand the effect on the environment on health. But really, it's not just the exposure from outside. Although we say exposure, we think of exposure as an external exposure. The term actually encompasses an external exposure in addition to internal exposure. So think about, your genomics and your metabolomics that can interact with the environment from outside to result in a health effect. And also the personal exposome, where, your exercise and your what we used to call behavioral kind of exposures. So all of this kind of the totality, thinking about it from a more of an umbrella term, totality of the exposures all the way from outside to inside to personal exposures that can impact health and impact healthcare utilization, resources, and costs, and so on and so forth.
I mean, this is tremendous because obviously when we see patients and take care of them, we see them periodically or episodically.
Yes.
And we have to think, besides reliance on medications and compliance of medications, is what is this environment that they're exposed to, even from the early days.
Correct.
How do you measure the effect of the environment? Are there any quantitative parameters? What is it nowadays? Technology has certainly improved so much.
Yeah. So I think of it as a pyramid, right? So for the totality of the population, we have data that's somewhat dirty, so to speak. It's noisy data. And let's talk about air pollution because it's probably the most widely studied. So air pollution, for example, we can get estimates of particulate matter, which is the solid particles that are in the air that we breathe every day. And there are models that uses satellite imagery, uses satellite data with kind of machine learning and models that can really estimate the individual exposure in your neighborhood, whether it's in your house or your work area or your commute and whatnot. And this is fairly accurate. When you talk about big population, it's probably as accurate as anything else that we measure in medicine. But nowadays, we have more and more detailed data that is really even from wearable devices. So we can measure air pollution from wearable devices. We can measure air pollution indoor, and these are not things that are futuristic. You can go to any store right now and you can buy an air monitor that you can put in your house that measures minute by minute air pollution levels. There are monitors that are affordable that you can wear, similar to watches and things like that, that can estimate the air pollution, the personal air pollution exposure. And not just, and I gave you an example of air pollution, but really it can measure noise, it can measure humidity, it can measure a lot of different things. So really it depends on what exposure we're measuring. Some things are a little bit more, cumbersome than others. For example, trace metals measurements in the water are a little bit more tricky compared with air pollution and so on and so forth. But the technology is evolving to allow us to be personalized in terms of exposures, assessment, and so on and so forth.
I mean, traditionally we thought that, air pollution is predominantly lung because you breathe the air, et cetera, but I know the data is amazing regarding cardiovascular disease and tell us about what could be the mechanism of at the molecular level or at the arterial level. Yes. I know there are effects there, and what is the effect on cardiac function and coronary disease and mortality? How much of that is impactful, you think?
Right. So there is a story that has been built over the past 2-3 decades, and there is a story that continues to build. So there's a lot of evidence that has been built to know that really air pollution is causal in heart disease. And you're right, people think of respiratory diseases as primary effects, but we're seeing that cardiovascular disease that's attributable to air pollution globally is really exceeding, the most common cause of death, for example, that is attributable to air pollution, meaning that cardiovascular disease is predominant. And that is important because as practicing cardiologists, this is becoming in our wheelhouse. And if you go to ACC, AHA, all these conferences, you see more and more people are talking about this, although we're not traditionally been trained in it. So what we know about the air pollution, at least the air pollution story, is that air pollution is the most important environmental risk factor for cardiovascular disease. The impact is known from not only epidemiologic studies, but also there is, believe it or not, there's randomized clinical trials that exposed people, but also took away exposure using filtration. And both of these trials, some of them are randomized, sham-controlled, blinded, all sorts of, highest level of evidence that showed that air pollution exposure can increase blood pressure. Air pollution exposure can worsen insulin resistance. And obviously, by the virtue of having these two components, cardiovascular risk factors, you can have a lot of downstream impact on heart health, from mechanics to arterial disease to atherosclerosis to all sorts of things. But there's a lot of beyond this hour of talking, I think there's a lot of evidence to suggest that there is inflammation that happens locally in the lungs that can really translate into the rest of the organs. These particles, some of them called ultrafine particles, they can actually translocate across the alveoli to the blood stream, and they can go to different organs and they can deposit. And we see evidence of those happening. So when you look at animal studies, for example, we see really broad transcriptomic changes, epigenomic changes that can be impacted by air pollution exposure, controlled experiments. And the same thing has been replicated in humans as well.
And just to jump right in, same for obesity.
Yeah, that's what I'm thinking.
The chronic inflammation, that's kind of the underlying physiopathological driver of obesity, has been linked to air pollution as well. And so it's not the only reason for the obesity epidemic we're seeing in the last 30 years and the growing impact of obesity and cardiovascular disease, but it's definitely a very valid research topic and a very valid idea on how air pollution and the environment actually impact obesity and then the cardiovascular diseases associated with that.
In addition, I know there are data, you can share that with us, on the environment, nature, green versus, cement exposures for overall health, cardiometabolic health.
Yes.
Many other things. How strong are these data?
Yeah, so when we think about the environment, has been unfortunately taken into the negative context typically, right? When we think about environment, we think of pollution, we think of bad things. But environment can be actually the solution as well, right? When we think about healthy environment, whether it's healthy food environment or what you're talking about, which is nature access, green space, and so on and so forth, that is all have been at least epidemiologically linked with better health. How much of that is really social determinants of health, which which Dr. Nasir may speak about later, remains unknown because unfortunately there is an environmental justice problem, right? Where the same individuals who have adverse social determinants of health also have poor access to nature, have poor access to green. But nevertheless, and I think when you think about it in terms of kind of as an assessment, when you talk about your patient about cardiovascular risk assessment, estimating these becomes helpful and additive to the regular social determinants of health when we talk about cardiovascular disease and other health outcomes. And there is, believe it or not, again, there are randomized trials to actually understand the causal impact of green space and vegetation impact on health. I know there's a study, the big study in Louisville, where they're doing cluster randomization of neighborhoods, where there's greening of areas, where they're planting trees. I think 500,000 trees that are being planted in unique locations, and testing how people cardiovascular health metrics happen before, measured before and after. So the story is still building. Is it causal? We don't know for sure, but there is some mechanisms to suggest that green space can actually counteract air pollution, counteract temperature changes, and so on and so forth. We know that they're causal in heart disease.
And hopefully some of our city planners, in addition, many of our physicians and healthcare providers actually are in positions of leadership to be able to make change and think about that. And before going to the social determinants, is there reversibility in the process? Meaning somebody's lived 10 years plus in such an environment. I don't know if there are some data, and then they relocate to a friendlier environment, health-friendlier environment. Yes. Is there reversibility in this process?
So I would say the highest level of evidence we have is from animal studies, where we, in mice, we did experiments where we exposed mice to air pollution, and we measured what in terms of epigenomics and so on and so forth, and then we reversed it. And a lot of the changes, the adverse changes that happen in multiple organs were actually reversed with reversal of exposure. So that's one. Well, there's also epidemiologic evidence from the Veteran Affairs System, where the electronic health records have been, been implemented in a long time ago, where we see patients who live in adverse environments, whether it's high air pollution and so on and so forth, and we move them to they move to an area that has a healthier environment, their cardiometabolic health parameters improve. And there's also a randomized trial, again, where we, the HUD Department of Housing, they randomized women and children who live in high poverty areas. And they randomized them to housing vouchers, basically kind of forcing them to move to a more friendly environment, healthy environment. And they saw that down the road, 5 to 10 years down the road, diabetes and incidence of obesity kind of got reduced significantly in a randomized fashion. So these kind of, it's a totality of evidence suggests that some of this is reversible. To what degree and how long and how much remains to be studied.
Goes to the previous saying many years ago, tell me what your zip code is. Yes. I'll tell you conceivably what your outcome is like.
Correct.
Khurram, social determinants of health. Your perspective on it, what is it? Obviously, there are multiple factors there. You're an expert on this. You've written so much, you and your colleagues. Your thoughts about it?
Well, first of all, thank you so much for getting everyone together to discuss this critical topic. I think so, which you highlighted so much under-recognized, but when we're looking through the lens, especially from the cardiometabolic disease, holds such a critical importance. Of course, we spoke about a lot around the exposome and the environment, and when you're thinking from a social determinants, you may think that maybe they are two sides of the same coin, go hand in hand, maybe a continuum, but critically when you start looking deeply, they are interdependent, but maybe some different separate constructs. Historically, social determinants are thought about your day-to-day reality and circumstances. Where do you live? What's your neighborhood looks like? You just spoke about the zip code providing so much information. What type of work do you do? Night shifts, day shifts? How much do you earn? What level of education have you had? What's your social network, support network, your transportations, your neighborhood build? all of this. And when you start thinking, and we clearly know access to healthcare and all of these factors have been shown historically to be associated with determinants of health, poor health, your outcomes, how well you're going to be doing. But when you're trying to tie them, I think so from a social determinant and exposome interaction, I think these are the drivers actually setting the stage that what you will actually be exposed to, your cumulative exposures. Of course, we spoke a lot about air pollution. I would say there are many other interesting exposures. Your exposures to healthy, unhealthy diet, your exposure about physical activity and chronic stress and sleep, all of those which mechanically and have biologically been shown, as we discussed, causing inflammation, endothelial dysfunction, hypertension, leading to obesity, increased risk of the diabetes. So we clearly know that all of these increases the risk of the cardiometabolic. Now you look into from a very big social construct, income and neighborhoods. We have shown within our own Houston Methodist data that patients coming to Houston Methodist who are of low income or residing in underserved communities have a significantly higher risk of cardiometabolic disease, especially obesity. And the question is why? Because these low-income individuals who are living in those neighborhoods are exposed to much higher air pollution. Their environment build is unsafe. That doesn't allow them to participate in more physical activity, leading to chronic stress. Walkability is poor. They have poor access to healthy food. Transportation is a big issue. Noise pollution leading to poor sleep, all eventually contributing to this increased risk of cardiometabolic disease. And then you compound that they have access issues, health literacy issues. And as a system-wide, we have seen that most of these individuals do not get the best care that they need to. Even general counseling on risk factors, screening, and simple prescriptions just around statin doesn't even happen for them. So in essence, I think, of course, when we're thinking about exposures and exposomes, and I think there is a drive and need to be, we can impact air pollution. But if we are not going to address the underlying drivers, I think so the story is half told. So it's just different pieces of the puzzle. If you want to truly look at the bigger solutions, we have to put them together to look at the big picture.
That is such a good point. And it goes back to the idea of considering behaviors as part of the exposome and the social determinants of health. And that has been so evident in the obesity management. Obesity has been defined as a disease 11 years ago, and we're still so far away from treating it as a disease. For the majority of the scientific community out there, and for the majority of our patients, unfortunately, obesity is seen as a fault, as a lack of willpower. And that goes to the same behavior, like, oh, you should just eat less and exercise more. We have to recognize that eating less, exercise more is not the answer. And also that for a lot of those patients, it's just not possible. It's just not possible. There's no access to healthy food. There's food swamps. There's food desert. There's no access to an actual fresh, healthy diet. They don't know how to manage that because nobody ever taught them. And there's no availability of structure that actually support the healthy behavior that we promote. And we have to kind of take a step back and consider all of those factors when we're in clinic seeing our patient.
And, you think about the current new solutions, quote unquote, right, of obesity, the GLP-1 agonists. These are certainly not affordable for communities like this and not available to them, the access is not there. But I think the construct is quite complex.
It is.
As to how do you address cardiometabolic and risk, et cetera. So to you and to you, Sadeer, how do we measure social determinants of health? I know at times on my electronic record, I see a number, I see something. I think we want to communicate that to our physicians. Obviously, how do you become more cognizant? All of us are stretched for time when we see patients. How do we measure it? And what could be individual practice approaches besides people looking at population health in general?
Right. So definitely, I would say a complex question, but I'll try to simplify. So, it's clearly, unless you measure, you cannot make a change. The first thing, at least for the health systems and for the physicians, I think so it's not only a great opportunity, but an obligation to us first realize that the social determinants of health play a major role as far as the disease burden, progression, and outcomes is concerned. So we need to get trained and re-educated in this space. Now, of course, how do we do that? That's kind of becomes a little bit of a complex. And I think that we can think it from two different mechanisms. One is, as Sadeer pointed out, globally, and we can easily, in today's day and age, where we have the address and the zip code, that can give us a bigger totality of an overall risk of an individual that encompasses their race, their potential insights on information, house build, access, transportation, food access, many of those issues. And clearly, and there is tremendous amount of data in this regard. If you take the zip codes and the distribution of underserved cohorts, it goes hand in hand with all the cardiometabolic disease. At national level, a lot of work has been led by Dr. Al-Kindi that has shown that. Also locally, we have seen that within our own backyard, we are seeing almost the similar signs. So that's one, how we measure. The second piece is actually we don't have to do much. EPIC already has a tool called the SDOH wheel, which in accumulation identifies 7 to 10 major social determinants of health. The challenge has been mostly how do we operationalize? Thankfully, over the last year and a half, efforts within our own institution, we went through smaller scales piloting where it could be identified. How do we then connect those individuals? Because you just don't want to identify, but then actually make some efforts. And that has last year, I think so, it at a system level that was turned on. And we have collected data close to almost 1 million individuals. And at American College of Cardiology, in a few months, we're showing that just 6 to 7 questions on that is one of the most potent predictor of the incidence of diabetes.
Are we marrying, obviously these are patient-derived or individual-derived data with questionnaires, et cetera, regarding this. Are we marrying this with an environment that may not be measured by the particular individual?
Yeah, so I think, the zip code, every one of us, right, as a practitioner, clinician, we see in our electronic health record across the United States, whenever you hover over the patient, you can see the zip code. Most of us have no idea what that zip code means, right? Other than your familiarity with your zip code and maybe the neighboring zip codes, right? And in reality, what we find, our research has been, both from Houston Methodist and nationally, we show that there are different fingerprints or different signatures for different diseases, right? So when we talk about social determinants of health, yes, it's great, but then, it's really not one thing, right? And then there is also different components of social and environmental determinants of health that can impact different diseases. And, we, as cardiology is expanding into obesity, into diabetes control, and so on and so forth, and renal disease as well, we start to think about really how we can characterize environmental and individual risk from social environmental standpoint that can determine someone's risk of a specific disease, not just the overall mortality, for example, because that's when you start to think about interventions, whether interventions on the social environmental drivers of health, but also interventions that are downstream, right? Medical interventions, which we can talk about, that can really mitigate and reduce the impact of the environment and social determinants of health with respect to cardiometabolic health. So to answer your question, yes, this is ongoing research that I think we're leading the nation. And at Houston,
hopefully we can marry these
correct,
together.
Yeah, and at the Houston Methodist, we're leading the nation in terms of integrating neighborhood characteristics with respect to environmental, social, and kind of area-based level, area-level kind of social and environmental determinants with individual determinants to create specific fingerprints for specific diseases that can be personalized, actionable, and it can trigger some downstream impact as well.
Your recommendations regarding all these effects and how do we attenuate this cardiometabolic effect? I know it's a big question, but
So do I have like half a day?
But we feel, at times you feel if you feel isolated from ability to act.
No, and that's right. We're talking about the big picture. We're talking about the big policies. We're talking about reduction of pollution. That's not something that we can do or we feel we can do in our day-to-day clinical practice, right? When you see the patient, that's the patient in front of you, you want to have actionable items. You want to have something to offer that patient to mitigate all of that. And I think that there's at least two things that we can literally integrate in our clinical practice on a day-to-day. One is education, and one is bias recognition. And those are very actionable and very practical. So I'll start with the biases. Because to me, for the exposome, if the exposome is the experience, anything that the patient is exposed to, then healthcare bias and clinician bias is a big part of that. And it's not something that we talked about because it's probably not the standard definition of the exposome. But if behavior and prior experiences kind of determine and shape the way we interact with our system, then the experience the patient has within the healthcare system is definitely part of the exposome. And again, obesity is a great example of that. Again, majority of patients feel like obesity is something they fail to do, right? And they feel judged by a lot of the providers they've been seeing. And that means that maybe they will go back for a follow-up and they, lack the opportunity for follow-ups and diagnosis. And so working on physician biases, starting from the recognition of obesity and cardiovascular risk factors, be it smoking, be it hypertension, as chronic diseases and not patient faults, and lack of proper recommended healthy behavior as a consequence of the social determinants of health more than just lack of patient willpower, I think goes a long way. And that is our own way we approach patients. And then we need to provide them with education, telling them this is what recommendations are, but I understand what your struggles are. Have a little bit more of an open conversation with them. If I just tell my patient, recommendation is you go out for a walk for 30 minutes every day, I should then ask them, can you do that? And sometimes the answer is, I would love to, I don't feel safe in my neighborhood. And that is literally—
I have 3 jobs that I
Right, or I don't have the time, or I'm a night worker, I'm a shift worker, I cannot get those 7 hours of sleep that you so, powerfully and passionately recommended for me. So I know it takes time, but this is a big enough conversation that requires us to take it a little bit slowly with our patient and kind of really distill down what we're talking about from the big system perspective into the clinical practice. And now that has to be paired with the big picture intervention, with the more green spaces. Let's plan for our cities to be more walkable. Let's reduce air pollution. Let's make sure we have policies in place for better food education. Let's make sure we have our newer generation have a better relationship with food, kind of as usual, the pendulum swings way back forward. So we went from a culture diet to a body acceptance concept, and obesity is still in the middle of all of that. We need to learn how to talk about all of this.
And I would just add to this, we talked about the bias and the behavioral interventions, but let's not forget about the medical interventions, right? So it turns out, and again, a randomized trial. So we actually did this work, we led this work where we looked at remember that the impact of the exposome on cardiovascular disease is mostly through traditional risk factors, meaning that, the exposome impact on myocardial infarction is through dyslipidemia, lipid increase, blood pressure increase, and so on and so forth, and obesity. So the question becomes what is in our ability as clinicians, simple clinicians sitting in the office? I'm not going to go change air pollution in Houston, but can I do something for this patient beyond the advice and behavioral intervention? Can I improve their blood pressure control? Can I improve their lipid? Can I improve their obesity? And it turns out in 3 randomized trials that we did this, the medical interventions that could be easy, cheap, simple, blood pressure lowering, right? Intensive blood pressure lowering, as was done in the SPRINT trial, can actually counteract the increase of the cardiovascular events due to air pollution. So that tells us that there are simple interventions that we can do in clinic that can really mitigate some of the exposures that we may not have as individuals, we may not have control over, but can mitigate that. And we presented work in just recently, a few months ago, in American Heart Association scientific meeting to suggest that mineralocorticoid antagonists can do the exact same thing. In patients who have very high risk diabetes, chronic kidney disease, in a randomized trial, if you give them mineralocorticoid receptor antagonists, they can actually counteract some of the bad effects that can happen due to air pollution. So the totality of evidence to us suggests that there is stuff that we can do in clinic. But unfortunately, that is going back to Dr. Nasir's point, is that this is complicated because the same patients that are exposed to adverse environment, whether it's social drivers of health or environmental drivers of health, are the ones that are not receiving, although they're high risk, they're the ones that are not receiving optimal medical therapy. So there are
We probably need to be more aggressive.
Correct, yeah.
And counteract.
Yes.
But that's where the challenge also comes, and I couldn't agree more. The recognition of clinicians where we have a tremendous ability to do that. Look, in all our training, I've seen that we never had any concerns talking about depression, sexual history, abuse, but issues around cost, income, your neighborhood, your ability to put food on the table versus medications kind of makes us a little nervous. And I think so this is where we have an obligation and an opportunity to lead, because about the significant trust the community and the patient have in us. So this topic and this conversation doesn't become stigmatized, as you pointed out. And yes, we can do a lot of things. Find cheaper generic options, avoid expensive testing. Blood pressure, as you pointed out, one of the key things is, yes, they're a high risk. You can prescribe them the cheaper generic medications, but one of the biggest challenge in a randomized clinical trial that we are seeing that those patients are, even when you're getting them for telehealth visits, are unable to show up. So remote blood pressure monitoring becomes great. Virtual visits, although they're helpful, but whether a community health worker who is a trusted member of their communities and can work with them into some of those interventions, I think so is needed. Another interventions, what happens if you supply fresh produce once a week as an intervention? So we are planning a similar study to see these are the type of the things that needs to happen. I think so it's a multi-sector approach. That's where we are as a health system, to realize there are many things that we can do to recognize, lead those conversations. Now, apart from our actions, we can always connect with local resources. Now, of course, that I don't think is a physician role. However, we are working with some of our RICE partners who have taken Rice University under the umbrella of the Digital Health Institute. We are creating a localized an app that can identify all the resources based on your own personal needs, tapping into your data and the notes and connecting with them. Now, these are great complex interventions that would need a different mindset of studying and finding the data, because in essence, this seems intuitive, but at times the results may be hard, because as I said, what we were seeing that rather than patients coming to the clinic, maybe if we can get them remote blood pressure monitoring and recruit them to do virtual visit would make it easy. And Dr. Al-Kindi will tell you that we're seeing that even that is hard. So it's complex. I think the health systems have a fiduciary duty to think about the ethical and the imperative of really addressing the root cause And physicians have a big role in championing this cause because the system, the community, and the society, they are the most trusted voice in this area.
I mean, I like your thoughts about going beyond the medical portion. Education is crucial. We have to empower and educate community leaders, religious organizations, foundations as to the importance of the environment. I think that would be tremendous.
And I think the other piece that has been started in a lot of other settings, not the cardiovascular space necessarily, is the patient advocacy groups and the peers-to-peers. Methodist has started this amazing peer-to-peer support group for transplant patients, in which patients were actually being evaluated and undergoing the kidney transplant protocol, actually have a mentor and a partner in somebody who's already done it. And that's somebody that, has an experience to share with them. It's not somebody that comes in with a white coat or an institutional function. It's somebody that's there to support them through the struggle that just living through that experience can actually bring. And I think that's a model that we can definitely tap into to make sure that we have more engagement from our patient, that we increase the trust from underserved community that historically have had lower trust level in the institution and in healthcare specifically. That's something that's another plug into this system-wide approach to patient care.
Even empowering patients and clinicians using data, that becomes super. I mean, for us, social and environmental drivers of health are a blind spot, quite honestly. And it's a huge one, right? It's a huge one. I mean, 90%, 80% of health disparities can be defined by environmental and social. And this is something that, going back to the first point you mentioned, how do we measure it? So empowering patients themselves, but also the clinicians and health systems using data-driven approaches to understand what are the determinants, what things can we impact, and how can we modify them, becomes hugely important in my opinion.
I think it's just going to take a little tweak in how we think about healthcare delivery, moving beyond the traditional paradigm and saying, can we do more, pragmatically meeting the patients where they are and trying to have solutions which are founded in the realities. Because again, we have class 1 evidence and what needs to be prescribed and what not and how often, but clearly the ground realities are there are extreme environmental, social challenges that we need to address. And unless and until we recognize, we may not have all the answers, and we don't. But the good part is that we are talking about it, right? And I think so this is the one biggest message I want to give to my physician colleagues. Let's start thinking about it. And we need all hands on the table because, yes, the solutions seems to be global, but the strategies have to be local. That's the key point.
Have to be local and within the community, because there is a community around, that environment. And I think love the education portion. Not only for the physician, the patient, but also, the community leaders within that to establish trust. The importance of fresh food. You use the term of desert, right?
Food desert.
Food desert, right? I mean, it really is amazing, which is true.
It's actually a concept of food pharmacy.
Food desert.
There's physician desert as well. There's clinic desert. But I mean, if you think about the trajectory of how medicine is practiced, right? Like we realized 100 years ago that people are dying from heart disease, right? And then going back, now we can identify myocardial infarction. Going forward, now we can identify risk factors, right? Lipidemia, and then diabetes. And then now we're going back into the primordial, right? And the drivers of these risk factors. So I think kind of medicine in general is moving, we should be moving into the community. And that's really the work that a lot of it is led by Dr. Nasir and others really how do we go into the community as clinicians, as healthcare services? How can we identify the right people, the right patients that can be intervened early, intensively, so that we can prevent all the downstream impacts.
And that's where education and trust is even more important, because if somebody's in the hospital and is sick, he's way more willing to follow advice on, you need to take 5 different pills for your current condition. It's a lot harder to discuss preventive strategies and tell somebody who's feeling absolutely fine, that has high blood pressure and high blood sugar, but it's not causing trouble at that time, that we're doing all of this to avoid you getting to the point where you cannot say no.
Yeah.
This is where the big prevention is.
So Sadeer, just on that, of course, these conditions impact so much the chronic conditions as we spoke about. But what's your thoughts on acute conditions? For example, still at a system level and at a physician level, we pay a lot of emphasis in heart failure, getting to advanced heart failure, or readmissions, or having somebody had a heart attack, preventing the next one, or dying from it, which are major matrices of what we call how we provide the quality of care. Where do you see the role of these insights and potential interventions that can help us maybe mitigate that too? Of course, we want to think about the chronic disease and prevention, but we have acute needs in this space. Your thoughts on that?
Yeah, I think the environment, although we spoke mostly about impacting risk factor, but it really impacts health across the spectrum of, the entire journey, right? And if you think about myocardial infarction, right, it can environmental, social determinants can impact diabetes risk, insulin resistance, and lipidemia that can lead to myocardial infarction, that can lead to recurrent myocardial infarction, and eventually cardiovascular death and heart failure and other things. So environment has been implicated. A lot of the work that we've done together and others that have been implicated at every stage, A, B, C, D, in disease. The question is, how do we intervene upon it? And I think that's where it becomes a personalized prevention story, right? How do we intervene on, not only intervene on the actual impactor, for example, the environment, whether it's air pollution, temperature, and things like that, but how can we use this information to identify the risk of this patient? So for example, if I give you information to tell you that this patient, because of their environment, they're at higher risk for heart failure, re-hospitalization, then you have in your ability, there's a lot of tools these days that are evidence-based to reduce that heart failure. And maybe this is where resource intensification, resource utilization in the right patient in a personalized precision medicine approach where we can really reduce that impact. But also, can we, similar to what you've been talking about, food and interventions, there are air pollution interventions, there is temperature mitigation interventions, and so on and so forth. So not only identification of the risk overall, but also identification of the driver. And I think this is stuff that is evolving. I think we'll probably hear more in the next couple of years, hopefully maybe in a repeated discussion like this, what the results look like.
I think there is great opportunity in today's day and age where we have an ability to really peel the onion and kind of further refine the risk. And the question is, how can, as you said, more intensification of treatment, more closer follow-up, maybe home visits, food pharmacy, providing the medication cheaper. And an area I'm very excited about is the potential provision of air filtration devices that could, and there is some data that's at least pointing in those directions. So I know that in the space of admissions and readmissions and mortality and risk, we have at a system level, most of the systems pay significant attention, but the effort seems to have plateaued. Maybe this is where the residual risk is that needs to be addressed.
Correct. Do you agree with me that you need, obviously we're talking to physicians, providers, they're stretched for time.
Yes.
One thing we can ask them is to have this on the radar screen. That's number one. Think about our own biases in that situation, educate patients, et cetera, but do we need, within our healthcare system or within public health arena, or in patient forums, if you will? We have patient forums for heart failure. Should we have patient forums where people interact and find solutions beyond the visit that we see patients with one-on-one where you're stretched for time? I really think so. I mean, I want your opinion. I think that would be maybe the last topic.
I can tell you that I would say it's a two-part solution. One is immediate, and one is which will take some more effort and more dialogue and more discussions. One is at a system level, there is no reason that this risk is not captured. We have the tools at the global level, at the individual level. We need more training, education, recognition of what it means, and how do we that modify our interactions with the patients around risk, management, cost, access. I think beyond that, we had a system level obligation where we can, even in the EHR, as we are working with Rice University in trying to create an app where direct referrals institutionally and within the community resources where that can address some of those. So I think so those are kind of the immediate one. The other one is going to take a little while, but I would say the leadership comes from the health systems. It will always be great bringing in urban policymakers and HEB and community leaders, religious leaders, conversations. The first thing is we are assuming what the solutions would be, and we need that engagement to understand what are your needs. Recently, actually, in conversation with the Harris Health County leaders, the biggest gap and need that has been identified by the community is actually environmental. This is a surprise. I would have never known if we didn't know
beautiful.
that. So we need to bring all of these together where say, how can we create more sustainable solution? And it is a responsibility of the entire society, not just the clinicians and the healthcare. I think so that's the long-term one, but we still have a lot of tools and processes that we can implement right now.
But no, I agree. In the 15 minutes that you are allotted for a follow-up visit, there's no way you can tackle any of this, right?
At least you'll have it on your radar screen.
But if you have it in your radar and you're cognizant of the fact that it's an important player in the conversation, then you may shape those 15 minutes in a different way.
Yes.
You can show up less biased to your patient. You can actually point them in the right direction instead of just ignoring it completely. So I think that's the first step we all need to take.
And also non-physician-led interventions, right? Community health workers. I think we've been so physician-centric for a while, and I think now it's the time to, especially when we move into prevention, primary, primordial, I think that it needs to be, yes, we empower, we kind of link and so on and so forth, but this should not be. Patients should be intervened, people should be intervened upon before they see us, before they come to us, because I feel like in this day and age, it's too late. By the time they come and see us, it's probably too late. There is much more to do afterwards, but there is, in this day and age, we have the ability to intervene on people ahead of coming to see us for symptoms.
So do you see the role of wearables and data apps to help support some of this?
Yeah, and I think, there is apps, wearables to identify geospatial methods, to identify hot pockets, hot areas that we can go and target. There is also avenue for screening, right? So people are going for lung cancer screening and so on and so forth, where there is digital tools now to identify how much plaque they have in their heart and how much liver fat and so on and so forth. So there's avenues, different avenues where people can be picked up and identified that can be targeted, so to speak, for intensive therapy, prevention, and so on and so forth, but also to empower patients and clinicians and healthcare systems.
I mean, the technology has improved so much. I mean, nowadays, even without a wearable, people can monitor your sleep, your health, conceivably the pollution, et cetera, and obviously you have to take a look at the whole environment and how can you interfere and improve on that environment, I think.
Everything around us is smart, even there's a smart toilet, so to speak.
Well, this has been an amazing discussion, really very enlightening, and I cannot thank you enough, you being with us today, but I cannot thank enough our expertise here around us, and I think we're fortunate to have such experts within our own institution to lead the way in so many ways on the effect of the environment on health in general, but particularly on cardiovascular health. I want to share with you something actually that we did not coordinate, but this is the DeBakey Cardiovascular Journal. that we put out every 2 months or so. And the last issue was dedicated to the exposome and cardiovascular health. So there would be articles from all of our panelists here on the environment and from other people, also experts in the field. And to tell you the truth, I love, the cover picture, which is an AI picture, I understand, right? An AI picture telling us about and identifying all these factors we just talked about, which are important. I know I started this panel discussion with what's our usual routine in seeing patients and focusing on the symptoms and the physical exam and some laboratories. But we have to think about where the environment of the individual that we're caring for, hopefully in the prevention mode, but also even in the acute care form, to try to improve their overall health. We are in the healthcare business, and it is caring about health. So we want to improve that overall. And hopefully you've enjoyed this panel discussion, and you may take a few things to your bedside evaluation of patients, and hopefully you'll make even more impact. Thank you again for joining us.
Thank you.
Thank you.